First of all, at the outset, I would like to thank MCure Pharmaceuticals and Dr. Jose and Dr. Vilesh, who spearhead the program. So I'll be talking to you about CRRT. So I'll just go into the history of chronic kidney replacement therapy. Currently, it is called chronic kidney replacement therapy. Every renal R has been replaced by K. Apart from that, there is nothing, no major change. So the first chronic kidney replacement therapy was done by Peter Kramer in Germany in 1957. And as you know, uh, this is a very rudimentary setup. So the blood is taken from the artery. So the real artery of the patient is cannulated. It was run through a hemofilter, and whatever the fluid that moved out as a result of the arterial pressure was collected, and that's a convective dialysis method. There is no dialysate flowing, and the purified blood was returned back into the vein. So this is a very rudimentary and a crude procedure, as you all can see. So this is a initial one, and after this, the technology has progressed, and currently we have very sophisticated machines like the Fresenius multi-filter. You have the Baxter Prismaflex Plus and the B-Brown machines. So we have quite the technology has improved quite a lot. So what is the spectrum of acute kidney replacement therapies which are available? As you know, acute kidney injury as defined by KDIGO is a sudden increase in the creatinine of about 0.3 from the baseline, or it is defined by urine output criteria of less than, I think someone should stop these markings happening. So there is a urine output criteria as well, less than 0.5 ml per kg per hour for more than 6 to 12 hours, or there is a 1.5 times increase in the creatinine over a period of 7 days. Administrator, can you stop the markings happening on the projection? So the kidney replacement modalities can be broadly classified into intermittent kidney replacement therapies, which are the ones which we commonly use, or this could be prolonged intermittent kidney replacement therapy, or it could be the continuous kidney replacement therapy. So acute kidney replacement therapy is what we normally do. Like the patient is taken for either intermittent hemodialysis or intermittent hemofiltration, but most commonly we use intermittent hemodialysis. And then there is a prolonged intermittent kidney replacement therapy, classically illustrated by SLED, or the sustained low efficiency dialysis, where the dialysis time is prolonged for a period of about 6 to 8 hours. And you have the continuous kidney replacement therapy. In general, any therapy which extends more than 24 hours is generally taken as continuous kidney replacement therapy, of which we have slow continuous ultrafiltration, continuous veno-venous hemodialysis, continuous veno-venous hemofiltration, continuous veno-venous hemodiafiltration. So today I'll be talking about just about the basics of continuous kidney replacement therapy. So the problems associated with the machine, the troubleshooting of the procedures, and the finer complications or the level of fluid that has to be administered will be taken up in a separate discussion altogether. So there are certain specific indications where chronic kidney replacement therapy is supposed to be beneficial. One is intracranial hypertension or conditions associated with elevated intracranial pressure, or that requiring the maintenance of therapeutic hypernatremia. Then, of course, continuous kidney replacement therapy is the best modality of choice. So, if you second indication would be a continuous correction of severe dysnatremia, like a sodium less than 120, or if it is more than 165, and where you require a continuous correction that needs to happen, then CRRT is most likely the most useful choice. Then cardiopulmonary failure requiring ECMO or other mechanical circulatory support. This again will have to be tackled in another discussion, because how do you do a CRRT along with an ECMO that needs a separate discussion as well. Then organ support in case of advanced heart or liver disease, unable to tolerate intermittent hemodialysis. Again, this is an indication. Then other condition would be something like a condition requiring a continuous solute removal due to high cell turnover or cell lysis, as in rhabdomyolysis or tumor lysis syndrome. So these are the certain indications which are specific that requires CRRT. So the advantages of CRRT is that it's hypertension effect is less. There is a less effect on intracranial pressure in at-risk patients, that is those patients with acute brain injury or acute liver failure. Then you have got a superior volume control, you have got a superior solute control, and it usually permits nutrition without restriction in protein, phosphate, or protein intake, and less hemodialysis nurse support is needed. However, the disadvantages of CRRT said it is decreased, that this solute clearance is often very slow, so you don't get an instantaneous solute clearance. There is increased need for circuit anticoagulation. There is increased risk of hypophosphatemia. It requires catheter placement. Of course, that is applicable to intermittent hemodialysis as well. There is increased risk of immobilization, more ICU nurse support, and increased overall cost. So the last one is the one which usually troubles us. So you have to know about certain terminologies which are used in CRRT. Ultrafiltrate is a fluid collected in the bag distal to the hemofilter is ultrafiltrate. Dialysate is a fluid which is instilled into the filter countercurrent to the flow of blood. Effluent is ultrafiltration along with the dialysate in case of CVSD. And if you are using continuous venous hemofiltration, it is a replacement fluid. Then the replacement fluid is a fluid which is instilled pre-filter or the post-filter to replace ultrafiltration volume. And the sieving coefficient is the ability of the substance to pass through the filter. So that is a ratio of the solute concentration in the filtrate to the solute concentration in the plasma. Then you have what is known as a solvent drag. Solvent drag is a free circulating unbound solute carried along with the water during ultrafiltration. So this is mainly the technique which is used in convective transport. Then certain terms which we'll introduce as we discuss about each component of continuous venous hemofiltration. So what is a membrane in continuous kidney replacement therapy? It usually uses a hollow fiber, high flux hemofilters, which can be used for hemodialysis or hemofiltration. High flux meaning the filter has got a larger size cutoff for solutes, around 10,000 Daltons, which is in contrast to low flux hemofilters, where we use in intermittent hemodialysis, which is about 1,000 Daltons. And you have to know what is known as a cutoff. A cutoff is a molecular size at which only 10% of a solute is filtered off. And in hemofiltration, all molecules whose molecular weight is less than the cutoff is eliminated equally and effectively. So this is one point that you should remember. So below the cutoff, everything is, all the molecules, irrespective of the molecular size, is completely cleared by hemofiltration. Then high flux hemofilters in hemofiltration can remove solutes up to 40,000 Daltons. Then you have to remember what is flux and what is efficiency. Efficiency is a maximal small molecular clearance that a given hemofilter can achieve, and it depends upon the membrane surface area and its permeability to solutes. And the clearance is primarily defined by the dialysate to the replacement fluid used, and hemofilters used in CRRT has a lower efficiency and have a smaller surface area. So the size is often 1 millimeter square, and they are usually uncharged membranes like AES. No absorption of middle or large molecular solutes happen in this procedure. So depending upon the size of the solutes which accumulate in acute kidney injury, they are classified into small solutes, middle molecules, low molecular weight proteins, and larger proteins. And the smaller solutes, the classical example is the urea. The middle molecules is a myoglobulin, B12, vancomycin. And in general, these three categories are removed by continuous venous hemofiltration or hemodialysis. Now, the vascular access which is used depends upon the pediatric, whether you are dealing with a pediatric population or with the adult population. Often there are guidelines on the length of the catheter that has to be put in the patients. As for example, in an adult patient, the formula is the height of the patient in centimeter divided by 10. You've got a 90% accuracy of placing the catheter at the correct site at the junction of the superior vena cava with the right atrium. So these are the guidelines on the size of the catheters, vasculates in the pediatric population as well as in the adult population. So we will discuss the principles as we go through each of these modalities in detail. So the first modality that we are discussing is continuous venous hemofiltration. So venous hemofiltration, the technique that we are using for solute clearance is convection. So the blood is taken from the patient's body and it is taken into the high flux hemofilter. There is no dialysate which is running. And the principle by which the solutes get cleared is through a process known as convection. So the convection is a process where solutes move across a semipermeable membrane along with the solvent. So the procedure that is used is known as a solvent drag. So you must, the key point that you understand, that you should understand is effectiveness is less dependent upon the molecular size. So the molecular substances which are cleared include the small molecules, the middle molecules, and cytokines are removed by hemofiltration. So there is a large movement of water across the semipermeable membrane. And because there is a large movement of water across the semipermeable membrane, you have to use a replacement fluid in this technique when you are using this technique. And after the blood goes through the hemofilter, it is returned back into the patient. Now, this is the simplified circuit diagram of what happens in continuous veno-venous hemofiltration. So you have to remember that there are three pumps. Essentially, there are three pumps, and only the blood flow is given in ml per minute. The replacement fluid solution rate is given in ml per hour, and the filtration rate is defined as ml per hour. So this is what you should remember. So the blood is flowing in this direction at a rate of around 170 ml per minute. And this contains potassium. This is an arbitrary representation of a patient. The potassium is 6, the creatinine is 5, and the urea is 80. And since the blood flow is very low, the filter is fully saturated, and you get a very good clearance. And the filtrate again contains the substances in the almost the same concentration as in the blood. So you get a potassium of 6, creatinine of 5, and the urea of 80, same as in the patient's blood. And you have to substitute by, you have to replace it by using a substitution fluid. And the substitution fluid is instilled at a particular rate that we'll come to it later. So the substitution fluid almost always contains the electrolytes in the almost the same physiological concentration as in the patient's blood. So you get a sodium of 140, chloride of 110, glucose of around 90, and it is infused back into the patient. So remember, the blood flow is in ml per minute. The replacement solution as well as the filtration is in ml per hour. That is what you should remember. So before going into the finer details, there are certain things that you should know. So when you are running blood like this and you are filtering all the fluid from all the water from the patient's blood, there is increased concentration of proteins and the coagulation factors in the hemofilter. So this will lead to the increased tendency for the hemofilter to clot. So the tendency for the filtration to clot is primarily dependent on a concept which is known as a filtration fraction. So filtration fraction is the amount of the water that is removed from through the hemofilter to the amount of the blood flow that happens through the filter times 100. So it just tells what is a percentage of the water that is removed when the blood flow happens through the filter. And the filtration fraction should always be kept less than 20% to 25% in order to prevent hemoconcentration as well as to prevent the clotting of the filter. And in order to happen, for this to happen, the blood flow should be at least 5 times the effluent flow rate. So what is meant by the effluent? So the effluent is this bag. So what is actually filtered off from the patient's blood, this is known as effluent in continuous kidney replacement therapy. So this is effluent. And in case of continuous veno-venous hemofiltration, it is the amount of filtrate that we obtain. So the blood flow should be approximately about the 5 times the effluent flow rate. And in the pre-dilution mode, there is then you can use the substitution fluid also in the pre-filter mode. So if you using it pre-filter, there is a decreased tendency for the blood to clot because you are diluting the blood and you are keeping the filtration fraction low. But the trade-off for pre-dilution mode is there will be decreased efficiency, and the therapeutic dose becomes 75% of the effluent flow rate. So this is what happens if you do it in a pre-dilution mode. So this is a pre-dilution mode where the substitution fluid is run pre-filter, and this is what happens. So what will happen is that the efficiency of the therapeutic efficiency of the filter of the procedure decreases to about 70% of the effluent flow rate. That is the main problem that will happen, but it can increase the lifespan of the filter. So what people generally do is that you give a fraction pre-filter and a fraction post-filter. So you split up the amount of the replacement fluid, pre-filter and post-filter. So that is how you tide over this situation. So what are the common replacement solutions that are used? So you got Prismasol and the Prismasate, which we commonly use as a replacement fluid. Again, you can see the concentration of the solutes. 140 is sodium. Chloride is in the range of 106 to 110. Bicarbonate is there. Lactate, potassium, calcium. So you can have a calcium free and a calcium in the range of 2.5 to 3.5. The importance of which we'll come to it later. You have magnesium, dextrose, and you have to notice that almost all the solutions don't have any phosphate. So the most important threat on a patient for a continuous procedure will be hypophosphatemia. And how does hypophosphatemia impact the recovery process? Is that phosphorus is needed for the muscles. So if there is severe hypophosphatemia, the muscle recovery becomes less. So if the patient is paralyzed and on ventilator, so the respiratory muscles won't work properly. You will have a delay in extubating the patient, and so on. So this is about the replacement solutions, and of course you have other replacement solutions as well. Now this slide is very important. You have to know two key parameters which are used in continuous kidney replacement therapy. So one is the therapeutic dose and one is the fluid removal. The most problems happen with CRRT because you confuse between these two parameters. So the therapeutic dose is the amount of the plasma fluid that is completely cleared of the substance to be eliminated per unit time. So the therapeutic dose for all continuous renal replacement procedure is around 20 to 30 ml per kg per hour. So this is a effluent flow. So the effluent flow should be approximately in the range of 20 to 30 ml per kg per hour. Usually it is taken around 20 to 25 ml per kg per hour. And in continuous veno-venous hyperfiltration, the therapeutic dose will be the effluent flow rate. So this is a effluent flow rate. This will tell about the therapeutic dose. So you have to know about the weight of the patient. Suppose this is a 70 kilo patient and you are running at 2000 ml per hour. That means 2000 by 70. That will be approximately around 30 ml per kg per hour. So that is a therapeutic dose that we have kept in this patient. So this is a effluent flow rate, and the effluent flow rate should always be approximately in the range of 20 to 30 ml per kg per hour. Is there any advantage of increasing the therapeutic dose? There are trials which are conducted, and the trials have shown that even if you keep the therapeutic dose around 35 ml per kg per hour, there is no increased benefit to the patient, no patient survival, nothing of advantage will happen. Now, the second concept that you have to remember is a fluid removal rate or the ultrafiltration net. So the net ultrafiltration is outflowing liquids minus the inflowing liquids. You just need to remember only this. Outflowing liquids minus inflowing liquids is a fluid removal. And in hemofiltration, the outflowing liquids is 2000 ml per hour. Inflowing liquids is 1900 ml per hour. So outflowing minus inflowing is a net ultrafiltration rate. That is 2000 minus 1900. This is around 100 ml per hour. That is a net ultrafiltration rate or the fluid removal that is targeted. So this is highly variable depending upon the clinical situation of the patient. A lot of variables are there. It depends upon whether the patient's kidney is recovering and if the kidney is putting out urine. You are transfusing more fluids, parenteral nutrition, lot of parameters are there. So the most important thing that you have to remember in continuous veno-venous hemofiltration is that you require a substitution fluid. No dialysate is running. Therapeutic dose is ultrafiltration flow rate. Fluid removal is, or the net ultrafiltration is the effluent flow rate minus the substitution flow rate. Now we'll come to the second procedure, that is continuous veno-venous hemodialysis. So in continuous veno-venous hemodialysis, the principle that is applied is diffusion. So the membrane is high flux membrane, hemofilter, and you are running a dialysate in and you are running a dialysate out. So the process is diffusion, and it's a solute transport across a semi-permeable membrane across a concentration gradient. The most important thing that you have to remember, it is best for small molecule clearance. So urea, all the small molecules will be best cleared by this technique. Unfortunately, it is not so good in clearing middle molecules and bigger cytokines. So this is a diffusive process. So you've got a dialysate inflow and a dialysate outflow. The blood runs here and it gets dialysed and it returns back into the patient's body. So here again, you have three pumps. One is the blood is running into the filter. Again, this is in ml per minute. And again, this dialysate flow, there is two pumps for the dialysate. One dialysate, one pump which pumps in the dialysate, and one pump which pulls out the dialysate, spent dialysate. This this is calibrated in ml per hour. So again, being a slow process, the outgoing dialysate, now this becomes a effluent flow rate, and the therapeutic dose is determined by the dialysate flow rate. And this again should be kept at 20 to 30 ml per kg per hour. That is a dialysate dose that you need to keep. The blood is completely saturated with the solutes. And as you can see, the concentration of the potassium, creatinine, and the urea in the spent dialysate matches that of the patient's blood. And here again, you have to, for a effective dialysis procedure to happen, you have to keep the blood flow at about 2.5 times the dialysate flow rate. So this is what you need to know when you want a good dialysis to happen. So here in hemodialysis, the therapeutic dose is a dialysate outflow rate. And the fluid removal is the difference between the delivery rates of the outgoing and the incoming dialysate pumps. So if the dialysate is pumped in at around, say, for example, 1900 ml per hour, and if the spent dialysate is running at 2000 ml per hour, the difference, that is 2000 minus 1900, that will be around 100 ml per hour, will be the fluid removal rate. So I hope you understand what is the therapeutic dose in continuous veno-venous hemodialysis and the fluid removal in continuous veno-venous hemodialysis. So this tells you about continuous veno-venous hemodialysis. So the most important things that you have to remember is the blood flow should be 2.5 times the dialysate flow rate, and the therapeutic dose is a dialysate outflow rate, and the fluid removal is the difference between the two pumps, dialysate pumps. Again, there are these are the replacement solutions that are used. You have the Prismasate, lot of other solutions commercially available, dialysate solutions. Then coming to the third procedure, that is continuous veno-venous hemodiafiltration. So continuous veno-venous hemodiafiltration. So you combine the process of hemofiltration as well as hemodialysis. So you have a blood pump which is flowing at around 135 ml per minute. You have a dialysate solution which runs in at 1000 ml per hour. This is a effluent flow rate. This is a dialysate or the filtrate that is running at around 2000 ml per hour. You've got a substitution fluid which is running at 900 ml per hour. So this one, the dialysate or the filtrate removal rate is actually the therapeutic dose. So the therapeutic dose is outflow rate of the dialysate or the filtrate mixture, that is operating rate of the training dialysate pump. So this is a therapeutic dose that you have to target. Then the fluid removal is the outflowing liquids minus the inflowing liquids. The outflowing liquids is only the effluent pump. This is a outflowing pump. The inflow is a dialysate inflow plus a substitution fluid. So these are the outgoing fluids. These are the ingoing fluids. So the difference between these two outgoing fluids and the ingoing fluids is a fluid removal rate. And for to achieve a optimal therapeutic dose, you have to keep the blood flow at around 4 times the effluent flow rate. So that is regarding continuous veno-venous hemodiafiltration. Now coming to anticoagulation. So for the blood to continuously flow through the hemofilter, you have to prevent coagulation of the filter, and naturally you require anticoagulants. And the most commonly used one is a heparin infusion. And heparin is run at a rate around 10 international units per kilogram per hour. And you target the APTT to less than 40 seconds. The INR, it should be around in the range of 1.5. And you monitor the APTT as well as INR. And you can run the heparin infusion 5 units to keep it somewhere in the range of 40, but it should be less than 60 seconds. And there are other techniques which can be used. One is regional heparin or a protamine. Protamine is an antagonist of heparin, and you run protamine at the outflow of the blood and to counter heparin. And you can use prostacyclin and as well as danaparide but these things are generally not used in our setup. Commonly we use heparin, and most of the time when you take these patients, they are really sick, and if you are especially taking a liver patient, you are worried about mm, anticoagulation to be excessive. So generally you use a saline dialysis. And there are other techniques to prevent the clotting in the hemofilter, and one is regional citrate anticoagulation. So the principle of regional citrate anticoagulation is that you infuse a citrate solution pre-dilution. So the citrate is a substance which will chelate calcium. So calcium is normally present, physiologically present in the patient's blood, and the calcium is needed for the activation of all the clotting factors. So when you add citrate into the patient's blood, the citrate will chelate the calcium, and the calcium in the patients in the hemofilter, that the blood will decrease. So the blood is kept in a fluid state within the hemofilter. And when the patient's blood is returned back into the patient's body, you add calcium to bring it to the physiological level. So you add calcium gluconate or calcium chloride, and the blood going back into the patient's blood will contain calcium in the appropriate concentration, and the coagulation procedure is maintained in the patient's blood. So is regional citrate anticoagulation effective? So this is the most important trial which has been run. This is not a rich trial. So they compared regional citrate versus systemic heparin anticoagulation for continuously renal replacement therapy in critically injured patients with acute kidney injury. So they have shown that the regional citrate anticoagulation, there is no difference in mortality between the regional citrate and the heparin treated group. And the regional citrate is most efficacious in promoting circuit half-life and reducing the risk of bleeding, and should be recommended as a priority anticoagulant for critically ill patients who require CRRT. So unless otherwise specified, regional citrate anticoagulation is the best for maintaining the hemofilter patency. Now, why is citrate so advantageous? So anticoagulation is strictly limited to the hemofilter. So it starts with the addition of citrate into the filter and stops with the addition of calcium in the returning blood. And the patient has full control of the anticoagulation property in vivo. And citrate is physiological, and it is a ubiquitously occurring molecule in metabolism. The patient's body, since it is a physiologically present thing in the blood, there are no allergies, intolerance, like heparin-induced thrombocytopenia doesn't occur. And formation of the calcium citrate complexes occur independently of the organ and according to stoichiometric laws. It is easily controllable. So the reactions are not complex, and you can control the reactions by going high on the calcium or low on the calcium, or altering the citrate concentration. Now, what is the citrate dose that is to be used? So the citrate dose depends upon the blood flow rate. This is one thing that you have to remember. And you are using around 3 to 4 millimoles of citrate per liter of the blood. And what will happen when you use citrate is that 3/4 of the calcium will form a complex with the citrate, and there will be a drop in the ionized calcium to less than 0.5 in the blood in the hemofilter. And the target of the drop should be something like 0.3 millimoles per liter. This should be the ideal calcium concentration, ionized calcium concentration of calcium in the blood in the hemofilter. And once the blood leaves the filter, the calcium is reinfused into the returning blood to keep the level of ionized calcium to around 1.2 millimoles per liter. And what happens to the calcium citrate in the hemofilter? Half of the calcium citrate in the hemofilter is dialyzed, remainder goes into the venous blood. And in the liver, it is converted into bicarbonate. And 1 molecule of citrate yields around 3 molecules of bicarbonate. So the dose of calcium substitution therefore depends upon the dialysis flow rate. And the normal substitution rate is around 1.5 to 2 millimoles of liter of outgoing dialysate flow rate. So the dose of citrate is dependent upon the blood flow rate, and the dose of calcium that is reinfused is dependent upon the dialysate flow rate. Why? Because this is cleared by the hemofilter. So, and what is the formula to convert 1 millimole of calcium to milligram per deciliter? You have to multiply by 4.008. So the dose of citrate is around 3 to 4 millimoles per liter of blood flow rate, and the dose of calcium substitution is 1.5 to 2 millimoles per liter of the dialysate flow rate. So this is the basic things about citrate and calcium. So this is a hemodiafiltration that is happening. Hemodialysis that is happening. And here you are using the citrate. So citrate is added into the patient's blood pre-filter. and the ionized calcium in the blood in the hemofilter is kept at 0.3 millimoles per liter. So this prevents the blood from clotting in the hemofilter. And when you are returning back into the patient, you are infusing calcium into the system, and the calcium is kept back at the concentration of around 1.2 millimoles per liter of ionized calcium. And the calcium citrate complexes that goes into the blood is converted back into the citrate is converted into bicarbonate. So one thing that you have to remember with regards to there are certain technical needs for regional citrate coagulation. So the dialysate should be calcium free. So the dialysis solution that is used in regional citrate anticoagulation should be calcium free. Why? Because if you are using calcium in the dialysate fluid, this calcium will diffuse from the dialysate into the blood, and it will negate the action of citrate. So the hypocalcemia does not occur. So you have to make sure that the calcium concentration in the dialysate is zero. And the dialysate bicarbonate concentration is in the subphysiological concentration, and the dialysate sodium is in a subphysiological concentration. So the dialysate sodium should not be 135. It is kept at a subphysiological concentration around 135. And the bicarbonate is also kept low. Why? Because we want some sodium to go out from the patient's blood into the dialysate, and some bicarbonate also to diffuse from the patient's blood into the dialysate. This is because this you are generating sodium bicarbonate here in the liver. So if you are continuously using a sodium of 135 or a bicarbonate of 25, you are actually going to generate more sodium bicarbonate, and the patient can run a risk of hypernatremia and metabolic alkalosis. So in order to prevent this, you keep it at a subphysiological range. Now the blood pump and the calcium infusate line. So you need an additional fourth line to infuse the calcium back into the patient's blood, and another line for the citrate, for a citrate pump also should be there. So the volume and rate of citrate infusion depends upon the concentration of the citrate in the solution and the blood flow rate. So the most important parameters which determine the volume and rate of citrate infusion is the volume is actually determined by the concentration of citrate. So if you are using a high concentration citrate, you need a low volume. And if you are using a low concentration citrate solution, you need a high volume. And the rate of citrate infusion again depends upon the volume as well as the blood flow rate. And the volume of citrate infusion infused has to be filtered from the blood to make the procedure balance neutral. Suppose you're running around 1 liter of additional citrate, you have to weigh that factor in also, and you have to remove that extra 1 liter from the patient's blood to prevent everything to be fluid balance. Now, these are certain citrate containing solutions which are available worldwide. This is one thing which you would be familiar with. One is Regiocit, used in the Baxter machine. Here you can see the concentration of all the solutes that are used. So how do you monitor during regional citrate anticoagulation? So the effectiveness of anticoagulation is assessed by measuring the post-filter ionized calcium concentration, and the target should be somewhere between 0.25 to 0.35. So if the post-filter calcium is more than 3.35, you have to increase the citrate dose. And if the post-filter calcium is less than 0.25, you have to reduce the citrate dose. This is self-explanatory. So the second parameter that you have to monitor is the blood pH. So you have to monitor the pH of the blood. Metabolic acidosis means less bicarbonate generation by the liver, or there is a low calcium citrate delivery. So if there is metabolic acidosis, you have to increase the citrate and the blood flow, or you can decrease the dialysate flow. So less of calcium citrate complex is filtered. But this is not a good thing because you are decreasing the therapeutic dose. So you have to either increase the blood flow rate or increase the citrate flow rate. Now, if the patient has metabolic alkalosis, it means that there is excess citrate delivery into the liver or membrane clogging. So metabolic alkalosis, you have to decrease the blood flow rate and citrate flow rate, or you have to increase the dialysate flow rate. These are the things which you will use if the patient develops metabolic alkalosis. All these parameters ideally should be measured every 8th hourly. Then systemic calcium and ionized calcium reflects in vivo coagulation status should be kept in the physiological range of 1.5 to 1.35 millimoles per liter. It is measured pre-filter. So the pre-filter terminology is actually a very confusing term. You can measure it anywhere along the patient's blood. And the systemic ionized calcium, if the systemic ionized calcium is less than 1.15, you have to increase the calcium substitution. And if the systemic calcium is ionized calcium is more than 1.35, you have to reduce calcium substitution. Now, there is a certain category of patients with liver disease. So, this liver failure patients, especially if you are working in a center which does liver transplant, you'll find that there is a very high demand for CRRT in these patients, because after liver transplant, the liver might not be able to pick up work very efficiently. Often these patients develop lactic acidosis, and though in fact the CRRT is not a good method to counter lactic acidosis, often these patients will have fluid overload, and they'll be hemodynamically unstable, and you would require CRRT. And there is a tendency for people to go for a saline dialysis. Now, there is a randomized control trial done by et al., and this was published in the CJASN, and they have compared whether regional citrate anticoagulation can be used in patients with liver disease. So they divided patients into two arms, no anticoagulation arm, and they used patients with the regional citrate anticoagulation. And the conclusion of the study, this visual abstract tells that regional citrate anticoagulation results in significantly longer filter half-life than no anticoagulation. However, there is a regional citrate anticoagulation is associated with slightly higher risk of hypocalcemia, severe hypocalcemia, and the main problem that they associated was with calcium disturbances. So, regional citrate anticoagulation, the current trend is to use regional citrate anticoagulation in patients with liver failure. Of course, you have to monitor very carefully. Now, in liver disease, you will have to be worried about citrate accumulation, because the liver may not be able to convert citrate in the patient's blood into sodium bicarbonate. So there will be citrate accumulation, and this condition is known as citrate lock or citrate toxicity. So how do you assess the presence of citrate accumulation is increasing the calcium substitution requirement. There'll be a drop in serum bicarbonate and metabolic acidosis. Metabolic acidosis happens because citrate levels builds up in the blood, and citrate is a acid. There'll be increase in the total calcium, and you have to measure the total calcium to the ionized calcium ratio. And if the total calcium to the ionized calcium ratio is more than 2.5, there's a risk of citrate accumulation. So this is how you diagnose citrate accumulation or citrate lock in patients with continuous kidney replacement therapy. Now, there are certain factors which affect continuous renal replacement therapy dose delivery. I'll just skip through it because these are often related to the complications, and which will deal in the another part of the lecture. So there will be the factors which affect CRRT is filter clotting or type of anticoagulation, decreasing sieving coefficient, secondary membrane formation or as a result of clogging of the membrane, filtration fraction. If the filtration fraction goes up, then there is a tendency for the filter to clot, and catheter-related problem like the type of catheter, site of placement, then circuit downtime. This is very important factor which determines the therapeutic dose, dialysis dose that is delivered. Suppose you have to stop the procedure in between to take the patient for procedures and CT scans, then the filter downtime will be decreased. Then there is a time of for diagnostic procedures and therapeutic interventions. Then these are techniques by which you can calculate the dose of dialysis that can be delivered. I'm not going into these details in this lecture. Now, this is an overview of the CRRT complications. One is the complications related to catheter placement. Of course, you know all these complications. And complications related to the extracorporeal circuit like allergic reactions, circuit thrombosis, hemolysis, hair embolism, hypothermia, thrombocytopenia. Then, of course, you have metabolic complications like complications of regional citrate anticoagulation, like citrate accumulation, citrate toxicity, hypernatremia, citrate buffer excess, hypomagnesemia. The one complication that you have to remember is hypophosphatemia, because the substitutions fluid currently used doesn't contain a lot of phosphate. Of course, there are commercially available preparations now available in the West which contain phosphate, and hypophosphatemia aggravate the respiratory muscle weakness. Then hypoglycemia, euglycemic glycemic ketoacidosis. Then these are the electrolyte abnormalities which can happen, which include hypophosphatemia, hypokalemia, hypernatremia, hypocalcemia, hypercalcemia, and hypomagnesemia. So this is summing up. These are the various methods, and we are not gone into slow continuous ultrafiltration. So continuous veno-venous hemofiltration, the procedure that is the principle that is used is convection. Blood flow is usually in this range, and the replacement fluid runs usually in this range of around 1000 to 3000 ml per hour. Net ultrafiltration is usually in all these procedures is around 0 to 300. Total ultrafiltration rate is again goes in this range. The components of ultrafiltration is the replacement fluid along with the net ultrafiltration. Whereas in continuous venous hemodialysis, the principle that is used is diffusion. Again, the ultrafiltration is only the net ultrafiltration, and the therapeutic dose is decided by the replacement fluid solution rate and the net ultrafiltration. Whereas in continuous venous hemodialysis, it is a dialysate flow rate along with the net ultrafiltration rate. And in continuous venous hemodiafiltration, the therapeutic dose is determined by the replacement solution rate, the dialysate flow rate, and the net ultrafiltration rate. And the principle that is used is diffusion with convection. And these are the typical prescription patterns which are of a patient weighing 70 kilo and with the hourly net fluid intake of 50 ml per hour. Suppose you are using continuous venous hemodialysis, you keep the blood flow at around 200 ml per minute, the dialysate flow at around 1000, the inflow pump, the dialysate outflow rate is around 1700 ml per hour. The net ultrafiltration rate is 70 ml. So the net dialysate outflow pump rate is around 1750 ml per hour. So that runs to around about 25 ml per kg per minute. So this is about the general prescription patterns that are used. So before winding up the topic, Georgie sir has asked me to enlighten you about the new website which we are going to launch, as Dr. Vilesh had said. This is the website of the Extracorporeal Nephrology Group. You can find it in this address. So what is this group? It is actually a group of nephrologists which are involved in online discussions and presenting topics which are of importance to nephrologists and as well as to the dialysis personnel. So there are talks and updates, and the website launch is going to be around on 11th of this month. So if you click at the site, you will go to this website, and this is there is a separate heading for the dialysis persons updates. And if you click at the dialysis persons updates, you can go through a list of talks which have been delivered in the early previous sessions. So my talk also, you can find it, the last talk which I had given in this group. So about hemodiafiltration. So thank you for listening to my talk. Over to you, Pradeep.
Thank you, Jose, for an excellent talk on CRRT. It was very enlightening and informative. Since, like Dr. Vilesh sir said, Jose sir has an emergency in the hospital, we'll take some few quick questions from the audience.